Looks like we are live. Welcome everybody to the first live quadcast featuring the one and onlys, Jane Philpott, André Picard, and Brian Goldman. It's a true privilege that they're able to do this with us. I gotta tell you straight up, I gotta apologize for the background noise. I decided to go to the hospital today to do this, knowing that my three kids are in the house and are going to cause a lot of ruckus, but I'm pretty sure it wouldn't be as bad as what's going on now. So I apologize for the background noise. There'll be a lot of muting um, for looking forward. But I want to just take a moment and just thank everyone that has been part of the team, and just to take a step back and look what is happening today. Like, what an accomplishment. Some of the great Canadian minds all together virtually to discuss our path forward with COVID-19. And it's truly special. I want to thank Julia, who's with us on the panel right now, actually, to facilitate questions. And she's an all-star, been great at, she's got her own website, spoonfulofscience.net. Shoot to that if you're looking for excellent nutritional advice. I want to thank Kim Sutton, who has been glorious and essential in establishing our new website, solvinghealthcare.ca. If you're interested at all, check out the affiliate link associated with the show. She'll give you a discount on designing your website, and also any online businesses that you might be establishing. Next, I want to thank our sponsor, the Better Together Project by Haley Harlick. This is something I'm really proud of her for setting up. It's a community for spouses of physicians, and really is something special. And it was established about a year ago, but really took off around COVID-19 to support families that are frontline staff and the spouses there. And her website's called the Flip Side of Life. But she's having an online event July 9th, the Better Together Project. And if you use the promo code Solving Healthcare, you'll get 10% off on sign-up fees. And my wife, she'll be attending. I just want to really commend Haley for the work that she's doing. Next, I want to thank all the frontline staff, the GoFundMe Frontline, Feed the Frontline staff initiative that took place over the last few months. We went out hoping to raise about $3,000, and we ended up raising over $32,000, and it was so meaningful, just seeing how the community rallied behind us. And I could tell you wholeheartedly, at all the places I worked at, they felt it. They felt the eMERGE staff, the ICU staff, the testers at the COVID sites. It meant a lot that we were thinking of them. And so I want to really commend you guys for the support. We've closed the fund now, but yeah, $32,000+ later, it's incredible. Almost last. One other charitable initiative we started, Bridges Over Barriers. This was really produced to help support kids that are of need, that, you know, with their basic needs, from their like shoes to bus passes and what have you. And this was put on by the social workers over at the Ottawa School District, and Ariel Burns has helped initiate that. And she reached out to us when COVID first hit, because a lot of families were needing that support, not being able to afford diapers, not to be able to afford food on their table because of the economic consequences of COVID-19. And so I just really wanted to bring up that initiative. And actually, our merchandise this month, if you like what you see, is going towards the Bridges Over Barrier Fund. So there'll be links attached to the comments there. Last thing before I introduce our amazing guests is, if you want to be able to get transcripts and the podcast version and a copy of this video, just type in MEGA in the comments section, and you'll get your own copy emailed to you. So yeah, please check that out. Okay, that is all I have to say before introducing, first off, Dr. Jane Philpott, general practitioner, former Minister of Health, incoming Dean for Queen's Medical School, and eventually we're also going to talk about your work at the Participation House because that was incredible. So welcome to the show.
Thanks for having me.
Absolutely. Next, I want to introduce Dr. Brian Goldman, ER physician, host of CBC's White Coat Black Art, and the new podcast, The Dose, which I got to tell you, Brian, the COVID content has been money. I've learned a lot through listening to that. Best-selling author of The Power of Kindness. Welcome to the show, my friend.
Really happy to be here in such great company. Thanks, and thanks for inviting me.
Absolutely, absolutely. And the one and only André Picard, who's made an appearance on the show before, and it was one of our most popular shows, Andre's, health reporter for the Globe and Mail, award-winning journalist, author of Matters of Life and Death, which is unbelievable. Every Canadian should read this. And welcome back, my friend. Thanks for coming back.
Thank you.
Absolutely. Okay, so where to begin? COVID-19, you guys, how are you guys feeling, by the way? Like, we've been out of isolation now. We're starting to see each other again. How are we feeling?
And none of us want to start. Absolutely none of us want to start. You know, I'll start just because we hate dead air, people who work in radio. I'm feeling that whatever the worst we'd prepared for in where I work didn't happen, and it may be because the preparations were great. I think a lot of my colleagues who work in the emergency department have had the feeling of standing on the precipice of a disaster that for many of us didn't come. And a lot of us, now of course it did come, it came in droves in long-term care facilities in places like Participation House, which we're going to hear about, and in homeless shelters, so vulnerable populations. But at a lot of hospitals, the volumes in the emergency department were down. And so, you know, we did have a number of protected code blues where we had to don the personal protective gear, you know, the extra special protection, face shields, double gloves, etc., and learnt those, you know, how to go through those procedures. I went through one or two myself, and you know, now we're taking a deep breath and we're seeing what's going to happen next. You know, volumes in the emergency department where I work at Sinai Health System are starting to creep up. But, you know, we're not seeing a lot of COVID these days. And are we through the first wave? Not sure, because I don't think we're doing a lot of good testing in the province of Ontario, comprehensive testing, even though the numbers are up. And as we start to open things up and have, you know, more people returning to business, I notice there's a lot more traffic on the streets. Some people are wearing masks, some people aren't. I still think there's a fair amount of confusion in the general public as to what they should do. And so I'm not sure what's going to happen next while we wait for a vaccine.
Yeah, I mean, I think we all kind of felt that, especially outside of the GTA, like we really were not hit hard here in Ottawa. Our ICUs were never overrun. The emergency rooms were never overrun. So it has been a lot of anticipation, and that talk of the second wave, that's another big topic of discussion too. But how would you, maybe Jane or Andre, how would you grade or how would you evaluate how we've done nationally in terms of managing COVID-19?
Andre, do you want to go? You start with an A.
Oh, I got the short straw. I think, you know, it hasn't been one epidemic. It's been many different outbreaks around the country. So we have to grade it, I think, almost province by province, almost region by region. And it's very much like healthcare itself. I think there's very much a west to east gradient. We know in the west, people are healthier, better outcomes, better health systems. And we've really kind of fell apart in Ontario and Quebec. I think that's been some real lacking. I'm trying to think of polite words. There's been some failures.
No need for politeness here.
Well, I'll have to be semi-polite. But you know, what we're down to now is we have outbreaks in Montreal and Toronto, and the rest of the country is sort of, you know, it's pretty concentrated in those two centers now, and that's both good and bad. It's good in that we have it in a narrow confine, but it's bad in that these are big cities with the potential to blow up. So unlike our other two guests, I have it easy. They've been working on the front lines, and I toil behind a keyboard, so it's pretty easy. Even though I'm in the epicenter of the epidemic, Montreal, it's pretty, life goes on. My biggest risk is Twitter overdose as opposed to infection. So I'll leave the expertise, the frontline stuff to our expert guests.
Nonsense, Andre. You're writing what we're often thinking. So thank you very much. We consider you a better than honorary member of the front lines.
Any thoughts, Jane?
Well, you know, and kind of going back to your first question in terms of how we're feeling overall, I'm generally an optimistic person. I try to always look at things with as much of a positive light as I can. But I would have to say I'm pretty worried. Yes, it's true. You know, we're kind of slightly over the hump of the first wave, but as Andre indicated, the numbers in Ontario and Quebec are still terrible, and we are dealing with an increasingly focused epidemic, not just focused in the big cities of Toronto and Montreal, but if you break it down to who's being hit in the greater Toronto and greater Montreal area, you're starting to see geographic foci, and then even within those geographic foci, you're seeing the socioeconomic background of those who are hardest hit, and of course, looking at vulnerable populations, the worst of which, of course, being the elderly, with somewhere between 80 and 85% of deaths being amongst the elderly. And there are obviously many other vulnerable groups that, if they haven't yet been hit this time, are still at very greatly increased risk compared to the rest of the population. I saw a really horrible outbreak, which is finally almost over in the Participation House. But for a couple of weeks there, we were dealing with a facility where we had 40 out of 42 residents who were COVID positive, 57 staff who were infected with COVID. It was, there were days where I felt like I was in a war zone. It was a frightening experience and a really tough one. And you realize that the resources within our healthcare system are unevenly distributed, and this is not new, but certainly in the sort of March, April days, there were not necessarily, in retrospect, not necessarily the best decisions made in terms of where those resources would go. And as a result, people suffered.
Yeah, and that's a good point. Like, if we could redo this, like if we could really, step back. And the reason I mention this too is because if there is a second wave, we should be thinking about the lessons we're learning here. How do you think we could have done a better job protecting our vulnerable? Like,
well, boy, I wish every one of us would be happy if we could go back and do things differently. Hindsight is amazing, and there are many ways that we would have pushed harder. I mean, how far back do we get to go, right? Can we go back several years and invest in public health and build a really great public health infrastructure and put in some really powerful public health legislation federally and provincially? Can we invest in housing and all of those things? So, I mean, obviously, there are all kinds of things that we would do differently if we could go back far enough. But I think there aren't very many who really saw how bad this would be. And there certainly were not a lot of voices in the early days saying, hey, let's not just get the hospitals ready, let's get the long-term care facilities ready, let's get the group homes and the shelters prepared and educated in terms of protection. there are a lot of things we would do differently, and we sure better be ready for the second wave and make sure that PPE is there and the public health education is there. And we have a heck of a lot of work to do to strengthen our public health systems.
So to what Jane just said about protecting, doing a better job of protecting the vulnerable and addressing those social determinants of health, you know, in the community and in long-term care facilities, which I think is absolutely correct. If I could have added one more thing, it would have been the best state-of-the-art testing and contact tracing using all technologies. And now, if when there's an inquiry looking at our response, our initial response to COVID-19, you know, if it turns out that we couldn't, that the province of Ontario, for instance, couldn't have cranked out tests any faster than they did, then okay, I'm okay with that. But there are many, many people who've been watching this far smarter than I am in disease surveillance, infectious disease, public health, Dalla School of Public Health, who have said that Ontario could have done a much better job procuring tests, hiring staff to administer the tests, hiring, purchasing enough reagents, test kits, and doing the contact tracing, which had we done it, we would have been in a much better position to know where the hotspots were and address the issues of who was becoming infected and why. And had we done that, I think we would be in a better situation than we are right now.
Yeah, that whole issue with testing, like I really wonder how much of it was availability. You know, because like if I'm assuming this was pretty global, national, where the criteria initially for testing was quite specific. It was like obviously needed to travel, come from China or Wuhan area, and now we're allowing for obviously a lot more broader testing. And I'm not sure if that's because of availability or just because of, you know, I hate to say it, maybe cost savings initially. I don't know, you know, but it certainly would have and still is a key component to us being able to get back to any form of normal life and also to contain as much as we can. One question I do have to you though, is our whole goal though was flattening the curve and to really make sure our healthcare systems aren't being overrun. And my sense is that the goals are changing constantly. And I want to hear from you guys. Do you guys feel the same way? Like, because our curve right now is flat. Our hospitals, locally are not being overrun. What's your guys' sense in terms of like our overall objectives? Has that changed in your mind?
I think the overall objective is to, minimize the damage to the public. So I think that remains the same. The large goal is the same, right? We don't want to have our hospitals overwhelmed. But beyond that, now that we've been at this for a while, I think we have to be much more specific. As Jane said, there's all these hotspots springing up, and there's going to be more of them as people go back to work. I think the workplace is turning out to be our next big challenge. So we're seeing people going back to work. We're seeing big numbers of infections in farm workers, factory workers. And, what happens when you start going back to 60-story office towers with crowded elevators and subways, et cetera? So I think the challenge has become much more specific, but the overall goal remains the same. We know people are going to get infected, but we try to minimize that. And then I think the single most important thing is to have the capacity to snuff out an outbreak when it happens. They're going to happen, there's no question, but let's not let them spread like wildfire. And the only way we can do that is with really good testing and tracing and isolation. And some provinces are doing that well. And again, Ontario and Quebec are not doing that well. And I think that's why we have to be concerned about the way they're opening up, much more so than Alberta or BC.
So combine that, Andre, with the fact that I don't know what percentage of the population has actually been infected. I've heard Alison McGeer in the last few weeks say 3%. If 3% of the population has been infected, if it's 5%, That's, out of a potential of 70 to 80% of the population becoming infected. So flattening the curve has bought us time, but time to do what? And as you've said, I mean, that's what we need to do. To be able to swoop in to a hotspot and discover as quickly as possible, who's infected and who they're at risk of transmitting the infection to. You have to have on the spot testing, and I'm not at all convinced that we're up to that task. I think that public health units do a relatively good job once the cat's out of the bag. Once there's a meat packing plant or a factory where there's an outbreak, they shut it down, and they do a good job of contact tracing. It would be nice if they could do that before there's a massive outbreak in that facility. And I haven't seen, perhaps, I haven't been reading a lot about what's going on in British Columbia. Have they done a better job of swooping in and controlling outbreaks before they become larger?
Yeah, I think there's no question they have. They had the first nursing home outbreak, Lynn Valley, and then they really set the standard. And what I'm puzzled by is why other provinces didn't follow suit, because they did all the right things in response to that. Single staffing, you couldn't move around. The public health director, Bonnie Henry, took over the staffing of homes, etc. So we know what works, and it's that Canadian disease of provinces not learning from other jurisdictions.
Which is what we always say is so great about the Canadian federalism, is that everybody can experiment and learn from one another. But here we're having a terrible experiment going on, and people are suffering, and I don't see as much learning as there should be from those who are doing the worst. I mean, I would just go back to the comments around the fact that it's, I think we're getting complacent. We're saying, oh, we're flattening. Well, flattening is not good enough. We got to get over the hump and back down to zero. We're seeing Spain today not having any new cases, and they were in a terrible, dire situation just a few weeks ahead of us generally as far as the curve goes. But in Ontario, we flatlined with 300, 400 new cases a day across the country, well over 100 deaths every day still. We're not seeing the kind of bending of that curve that we ought to be seeing. And I do think there needs to be, and hopefully there is, serious examination as to what that's all about. I still say some of the roots of this are a very weak public health infrastructure, which, why has that been worse in Ontario and Quebec than the rest of the country? It's a little bit hard to say. And as Brian says, we'll have to kind of examine all of this a little bit later. But these agencies, and it's largely been run through the regional public health units, have not historically been well staffed. Certainly not enough people that were trained in what contact tracing is like. It's probably a lot harder than any of us imagine. And the other thing I don't think we've brought up yet is it's been a data jungle. The understanding where the cases are, where those tests are being done, when they're coming back positive, is somebody actually on top of it and getting that contact tracing started within 24 hours. We have a ton of work to do here in Ontario still.
Yeah, there's a lot of great points there, like Brian specifically, like the not really having a sense of how rampant is the COVID-19 been in the population? Like, is it 3%? Is it 5%? Is it like you're seeing numbers in California early, like 6 weeks ago, like at 12%, and that's important data. And getting back to Jane, your point too, in terms of like the mess of the data. The one thing I do want to say though is I always find it a little bit difficult to interpret the data. Like there's some concrete stuff like, hospitalization, ICU admission, deaths. But like when we just hear about like increased numbers in like I feel like the denominator is not the same than it was a couple weeks ago, you know, and I wish this was a little bit more apparent or more or standard in terms of, you know, this is what this means. And because a lot of the data to me, there's a lot of nuance there. Like, is it a localized when we see those increased cases? Is it a hot spot? Is it all in Toronto? And because that's different than just, you know, throughout Ontario that these numbers are going up. Because one thing I do want us to touch on is there is a consequences of us of us being in lockdown and so forth, which in my opinion, we don't talk about enough. You know, like we did a show with Michelle Ward on the increase in child abuse during these time periods. We worry about mental illness, drug abuse. So I really think we got to be clear personally on our goals and our objectives. And once we hit them, we think we got to talk about how we get back to normal life, if we can get back to normal life. But I'm talking a lot here. And I got some really important, beautiful guests.
You don't have a fire alarm going anymore.
I know. Yeah, I needed the fire alarm. But and the last thing I would say too is like the public health, investing in public health. I hope at the end of this we see the light. I hope we see how valuable it is to have that infrastructure in place. Because I mean, this is not going to be the only time we face a pandemic. So like that's such an important point, Jane.
Yeah, well, and Quad, you know, we had an inquiry led by Justice Archie Campbell into SARS, and many people, including me, said we're better prepared this time than we were for SARS. And now I'm not sure at all. I think we dropped the ball, and I think that public health infrastructure has frayed at the edges, and I think we're paying for that right now. I think overall we're paying for the fact that tax cuts were in ascendancy, and service cuts were part of that. And you know, but to get back to some of the things you were talking about, the reason why we harp on ICU admissions to hospital, and deaths is that they are the most robust indicators you have in a population that isn't doing enough testing. Those are the lag indicators that tell us. The problem is they tell us what was happening 3 or 4 weeks ago, not today. And if you want to control an outbreak where you've got, 30 to 40% of cases through asymptomatic transmission, then in the absence of testing, the only indicators you have are these lag indicators. And that's a huge problem here. So, you know, we talk about 300 cases out of what? Who are we testing? I can tell you this is a true story. A very close member of my family 6 weeks ago had classic symptoms of COVID, went to a COVID assessment center and was told, we're not testing you, just go home and self-isolate.
100%.
And she was sick for about 6 or 7 weeks. There's no doubt she had COVID-19, and she wasn't tested because those were the rules at the time, because we were rationing tests in this province.
And I think that will be one of the lessons from this, having spent the early part of the outbreak of the epidemic in a COVID assessment center in Markham before I moved over to work at Participation House. I've been dismayed at how we're good at following rules in healthcare. You know, and I think we shouldn't have been so good at following rules back then, because I think our clinical judgment in those early days, and by early days, I'm talking mid to late March, a doctor's clinical judgment is this person in front of me really should get a test, or the person that I've heard about that's waiting in the line that actually doesn't even get as far as being in front of the doctor, they should really get a test. And so I'm not sure how we will reconcile that going forward. I think it speaks to the fact that people on the front lines often can't get their voices heard as well as they might, because there were certainly lots of people trying to get the message through that we need to be testing more. And, you know, we don't get to go back in time. It's not a randomized controlled trial, but if we had tested more in those early days, most of us suspect that we'd be in better shape now.
Yeah. And it, you know, it also makes you wonder, like, you know, we don't have a time machine, but if you could go back to January 1st today and tell the Ontario government, if you spend $25 billion on testing, you'll save you'll save $150 billion in lost jobs and lost economy. Would they have done it? In a heartbeat today. But as Jane said, hindsight is 20/20.
Yeah. No, it's so true. But to me, what's a true measure of like a good government or population is like, what do you do now? Like, what are the next steps that you like? Show me that you've learned from I don't want mistakes or whatever the term might be. Like, let's fix this in the future. And because there's so many holes. There were so many holes. Like I mean, we did talk about the long-term care, which is, I mean, how long have we been talking about long-term care, about some of the care that's been involved there? The other thing, I mean, that is striking to me, or disappointing, is how like marginalized patient groups have been really significantly more impacted than other groups. It really, once again, going back to those social determinants of health, like how big of a factor that is in terms of your outcomes. And, you know, and hopefully, you know, this is at a higher level will be addressed. I know, Andre, you and I have talked a lot about, you know, social determinants and marginalized patient populations. What are your thoughts in terms of the experience so far?
Well, I think, you know, a lot of this was, we should have known it, right? We know that vulnerable populations are the canaries in the coal mine. They're always hit first by everything, by infectious diseases, by wars, by you name it. So they are vulnerable to all this stuff. So I don't think we did near enough, and I think we kind of have come up with too many excuses for it, especially long-term care. I think long-term care was pretty clear early on. BC had a really good warning sign there that this was a problem, and we just dragged our feet. You know, I think one of the biggest problems Canada has is we are very cautious about doing anything. I read something the other day which I thought was really well stated. It said that the biggest lesson of COVID-19 is that it's better to act quickly and be half wrong than to act slowly and be half wrong.
Oh,
we were in the latter category. We acted slowly and we still did things wrong. And everybody's going to make mistakes. So it's better the countries that have done best really just did stuff. They didn't always do the right stuff, but they acted. And we didn't do that. And what do we have as a result? We have literally thousands of our elders are dead, that many of them were, not all, but many of these cases were preventable. And we know that from other jurisdictions within Canada and other jurisdictions within the world. There are countries that have zero long-term care deaths. So there's no excuse for what happened here.
That's incredible.
You know, as I suggested earlier, we need to figure out how to take our blinders off and intentionally look for who else is at risk. Because as Andre said, we can predict who that will be. And I think about Indigenous peoples who live in very crowded communities with terrible health systems. They have, in Ontario at least, in the far north, been almost entirely spared to date. And I credit First Nations leaders with being super proactive on this. But, you know, this is with us for the next 18 to 24 months before we're likely to see a vaccine that's actually going to be in widespread use, and who really knows when that will happen. But those communities will not be able to avoid having someone bring COVID into their communities forever. And that we should have a strong focus on looking at those places to make sure that they are prepared. It's going to be, again, hard to make up for lost time, having not put a proper focus on First Nations-led health systems in remote communities. But we could probably go down a list right now and say, in the next 2 years, where are the outbreaks going to happen? Where are the outbreaks with bad outcomes in particular going to happen? And there are plenty of places where the focus should be. But as is always the case, the voices that we most need to hear are barely audible.
I think the indigenous communities is actually a really good success story that we don't think about enough. They were really battered by H1N1. There's massive death rates in those communities, and they were better prepared this time. They're better prepared than downtown Toronto. And to their credit, they acted. They didn't dither. They blocked off access. They did stuff that really prevented the spread of disease, and there's not enough credit, and they did it with very few resources. So I think we could take some comfort there that this, the actions there were really saved lives.
And to your point as well, Jane, like we talked to Mark Tyndall a couple weeks ago in terms of the BC experience, and he's been an advocate of having more housing and stuff for the homeless population. And this is one of a couple of positives that have come out of COVID. Like they, according to him, were able to establish some housing because they realized like if that goes through their group, like the disease can amplify significantly. And the BC government, public health, invested in that. And it just goes to show, and as we alluded to before, they haven't been hard hit. But yeah, it's that kind of, as you said, like think about who's going to be next, what the future will look like, and invest. Don't stand idle.
It's interesting that you say that and I agree. I think there's some factors there that we just don't understand. I visited the downtown east side a few months ago, and we did a show on White Coat Black Art about their Toros program, which is the tenant overdose response organizers. So these are people who visit the 15 to 20,000 people who live in single room occupancy hotel rooms in the downtown east side, delivering safe injection kits and delivering naloxone kits. And it's true. I spoke on the weekend on my show. I spoke to Dr. Daniel Calla, who's the chief of the emergency department at St. Paul's Hospital in Vancouver, and he said they've hardly seen COVID-19 in the downtown east side, let alone people dying of COVID-19. So we can pat ourselves, or they can pat themselves on the back and say that they've arranged for housing, but the people that I interviewed, that I visited, are still in those single room occupancy hotels, which are not pretty rooms by any stretch of the imagination. So there may be other factors at play that are reducing the rate of infection there. One of them is that they take care of one another. They have strong social networks, and they look out for one another. So there may be some other factors that we're not aware of. Interestingly, opioid overdoses are up in the downtown east side, fatal overdoses, and that's because people are overdosing on their own. They're not going to safe injection sites because they're afraid of getting COVID-19 at the safe injection site, which is a fallacy. They're not going to get it there, but they think they are.
Wow. Couple things to talk about. One, we alluded to some of the negative or secondary consequences of all this COVID-19. What has driven me nuts is, oh my God, is a fire alarm system, is the fact that people are so scared of contracting it. The people that are presenting to hospital these days are presenting so late, and it's so sad, whether it's their MI, whether it's their respiratory COPD ailment, they're presenting late because of fear. And I do feel like this is where we've failed people a bit, is like having that message of, if you need care, come to acute care. If you need medical attention, let's deal with that, and we're doing all we can in the hospital to reduce risk of transmission. I just wanted to mention that too. And then the other point I wanted to make in terms of things that we don't seem to understand, like there really seems to be, at least in my eyes and some evidence, some real strong correlation of obesity, diabetes, hypertension, like some risk factors that are associated with other, obviously, medical conditions. But this also seems to be linked to poor prognosis. And sometimes I wonder if part of the dialogue in the next little while should be like, hey, here are these risk factors. What can we do to reduce that? Like let's exercise, let's improve our nutrition, let's do stuff to reduce our risk of COVID. And in the worst case scenario, people just get healthier, you know. But back to your point though, there's just so many, to me, mysteries about this virus, like even clinically how it's behaved, like with the clots and the kidney disease and the delirium. So many parts of this is unique.
Well, part of that is that we thought of COVID-19 initially as a respiratory disease, and now we're seeing it more as a multi-system disease that's characterized by damage and inflammation to blood vessels that leads to clotting, that leads to the damage you're referring to, so increased risk of strokes and acute coronary syndrome, kidney failure, etc. And frankly, there's a lot that people on the front lines and researchers are trying to unpack as to the pathogenesis of the disease and to develop treatments that will prevent people who have a mild case from having a more severe case.
One of the other things that your comments bring up is the issue around behavioral science. And I think it's interesting to say, how else can we address risk factors like obesity or hypertension? And man, if you got the secret to that figured out so that we can do it better than we have, then you don't need a job running a podcast. You can, you're fiscally secure for a long time. But anyway, we're not good at behavior science, and doctors, I think, are not taught enough, and health professionals maybe in general aren't. We get a few courses on motivational interviewing, and then we're sent off to do our thing. But behavioral scientists have a lot to say in this pandemic, and we haven't used them, and I don't hear their voices being amplified. But you look at not just those kind of risk factors that you talked about, the biomedical ones, but what does it take to encourage young people to not gather in large groups in parks in Toronto? Where have we failed to explain that might be risky behavior? We kind of give trite, paternalizing messages about people staying home and expect that they're actually going to do what they're told. Any parent will tell you that you got to have some serious techniques and understanding of what it takes to encourage people to make decisions that public health might say in their best interest, but they have all of these other influences in their mind, all these other stressors in their life that make doing the right thing a heck of a lot harder than it can appear out of the mouths of the all-knowing public health experts.
So Jane, so mocking or stigmatizing people who went to Trinity Bellwoods is probably not a good way to motivate them to not to gather in groups. So what is the way to do it, to motivate them to follow public health instructions and advisories and guidelines?
Well, mocking and stigmatizing don't work for anything. But again, I'm going to hand this question over to André because he's the expert on this.
I don't know if I'm the expert, but I can, we like anecdotes in my business. So I look at what happened in Trinity Bellwood, and then I was reading right before that what was going on in a big park in Berlin. So where lots of young people gathered. So what did the police do in Berlin? They went around with their loudspeakers and they said, "Thank you very much for respecting social distancing. We appreciate how you're keeping your elders safe." None of this, "Oh, you're awful bunch of, hipsters and you're trying to kill everyone." That's not what they were doing. And the other thing is, I think you have to make rules clear. We have now circles in Trinity Bellwood Park. A lot of people mock that, but what's wrong with that? What's wrong with having, people would say, "Oh, they're stupid. They need circles." And I say, well, I guess we're stupid. We need lines on the road to know where to drive too. We need little stickers telling us what 2 meters are. There's nothing wrong with making rules easy for people. So I think there is a lot of behavioral science that you're quite right, Jane. We haven't tapped into that and learned lessons that we've known for a long time about other things and applied them to this epidemic.
And André, to that, I would add empathizing with the person you're trying to persuade. And for instance, there is a pilot program in Quebec City where new parents are visited by a vaccine counselor. And you know, this is the purpose, the long-term purpose is to increase vaccination rates by addressing vaccine anxieties and hesitancy. And what they do, their method is to provide information, but to begin in an empathetic way, an empathetic manner, approaching every parent and saying, you obviously want to do the best to keep your baby safe. And instead of positioning themselves in opposition to the person they're trying to persuade, they join them on the same team. And they have a success, an enviable success rate compared to any form of browbeating or lecturing. And
I know someone's written an excellent book about empathy, so.
I hear that may have happened at some point.
Amen. It's such a good point. Because I was actually wondering, my wife's a psychologist, and we were talking about, you know, the amount of fear messages that were coming through initially, and like when COVID was starting to appear, and we were wondering, like, from a behavioral science point of view, maybe this is what you need to set the bar, to really get people to obey. But the points you're making are fair. Like, you really want to create change. Like, I give this story every once in a while. My wife and I were at the DMV, or getting our license updated, and the lady at the desk was just super agitated, unfriendly, and something was up. And my personality is, you know, I get short too, and she's giving us attitude, and I'm like about to do my thing and be like, excuse me, and my wife grabs my hand and looks to the employee and goes, you know, sounds like you're having a tough day. You know, is everything okay? And the whole thing just diffused, and she just was like, yeah, thanks for asking. And she was the most pleasant person afterwards. But as you said, like, the carrot or the not using that stick could probably go a long way in terms of creating the nudges and the things necessary for us to really have that behavioral change. But
yeah, people are really anxious and worried and frustrated and lonely and bored, and then we hit them over the head with these sticks and browbeat them. We haven't got the approach right in terms of trying to say, this is really tough, and we get it that you haven't been with your friends for 2 months, but we're going to have to figure out a way to do this safely, and it's going to be better for us all in the long run. So we've got some work to do in getting that message correct.
Absolutely. I mean, has there been any? What are the positives you want to take away from this experience so far? Because to me, there's been quite a few, and I could point to a couple of things that, you know, all of you guys have done, but without putting words in your mouth, what are some of the positives you've seen during this pandemic?
Let me start. I'd like to start with Jane, Dr. Jane Philpott, volunteering her time and effort and putting her life on the line to work at Participation House. And in the same way, people in acute care hospitals from Sinai Health System to North York General to University Health Network and many others, lending their time to long-term care facilities to spell off exhausted care providers on the front lines there. That sense of duty and honor and helpfulness is one of the positives that I'm going to take from this horrible mess that our society is in right now.
Well, I would add as well that there are loads of positives. You know, not that we would ever wish this on any society, but just to kind of follow up on Brian's comments about my experiences working in Participation House. You know, I wish I never had to do that, because 6 people died. And it was a horribly traumatic experience. And the nurses and PSWs that have been there for a long time, they will be traumatized for the rest of their life by what they lived through. But having said that, it was, for me, working there absolutely has made me a better person. It taught me things that I would never have learned otherwise. And particularly getting to know the residents who live there, who are extraordinary people. I have a niece with very severe disabilities from Rett syndrome, and so I've come to understand a little bit about what it's like to be a family member of someone with a severe disability. But to work in a setting where you've got 42 adults who are completely dependent upon the people around them for their feeding, their bathing, their movement from a bed to a chair every single day. Wow, that's a very special place, and it really takes exceptional people to care day in, day out for 20, 30, 40 years for these people. And they have been out of our minds. We haven't paid attention to who these personal support workers are in the way that we should have. And they really are not just healthcare heroes in the year 2020. They've been doing heroic work for a very long time and have not had the attention they deserve. So we've all learned a lot from this, and I could go on with lots of other positive things, but I think that's one that needs to be shared.
I think that's a really important one, that we've learned that low wage workers are not low skilled workers, that these jobs are really difficult and they're really important. And we're starting to talk about maybe giving them a half decent wage now, and that's important. I think the other thing that we've really learned from this, from the long-term care debacle, is the importance of family caregivers. You know, we have family caregivers now who've been locked out for 2 months. And I think this is one of the biggest travesties going on now, is that we're not letting people in to do this care that they've been doing for years. We know that the paid staff are great, but they just can't do it all. The families are so essential, and this continued to lock them out. Ontario suggested today they're going to lock them out for another month or two. And I just think that's unconscionable for the residents, for the families, and for the system.
I mean, this is where I think I wish a more regionalized approach could make a lot more sense. Like, you know, if you're in Moose Jaw or wherever, an area where it's Kingston, where there's hardly any cases, you know, for our long-term care patients not to see their loved ones, it's, I don't know, we're still human beings. But just to echo too what Jane and Brian were saying, like, I've never felt more close to my colleagues than in this moment, like in these times, like when we've resuscitated and intubated and doing all the right things and seeing our COVID patients go through and seeing the community band behind us. And it's just been special. And like the heroism, like the RTs, the physiotherapists, the personal support workers that often don't get enough credit. It's unbelievable what the work that they're willing to put in. Obviously the nurses, obviously the docs. One thing I do want to say too is, you know, I saw some young staff, like young residents that would step in. We were short on staff like early on in the pandemic, when a lot of people need to be isolated after traveling, and they were willing to step up, and they knew what was at stake. And, you know, it almost puts a tear in my eye just thinking about what they're willing to sacrifice for the betterment of us all, you know. And I just, there's so many good things. And the other thing too is just some of the healthcare delivery, like the fact that, you know, we're more open to doing virtual care, I think is like about time. Like we were busting out shows on this early on, and like there's no reason you should be leaving your office for a 5-minute GP visit when you could just be on doing what we're doing and say, yo, can I get that prescription refilled, or here's my minor ailment. Like this, you know, we're in 2020. And so I'm hoping things like that will stick. But to me, there's been a lot of positive stories, that connection. So yeah, I think a lot of good overall, despite being scary.
Well, I think that virtual healthcare one is a really important one. How do we ensure that it stays? Because it's not only good for practitioners, but it's good for patients. But there's things that have to be addressed. We have to make sure we have decent internet around the country. You know, one of the paradoxes, I think, is that people who could most benefit from virtual care can't access it because they don't have decent internet in Northern Ontario and across large parts of the country. So we're spending money on all kinds of things, and rightly so, but let's pump a little extra money and do these things that are going to change care permanently and for the better.
Excellent. Excellent.
I know we're trying to say good things right now, but there are some things as we move forward into the next few weeks, the next phase. Some things that I'm concerned about. I'm very concerned about people, about frontline physicians, for instance, working in offices. You know, many have closed down their offices. They don't know what primary care is going to look like in the weeks and months ahead. And at first I thought, you know, is this some political ploy? Is this an argument for more money, an argument to accelerate payments for virtual visits? And I'm starting to get the impression, as some clinics close down permanently, that there are some massive changes that are taking place that are not being thought through. And I think that the consequences are going to be felt by patients who will have an even greater lack of primary care, of access to primary care than they've had in the past before the pandemic.
Wow. Well, I certainly hope not. Like, I mean, the amount of people searching for family docs and primary care. And I mean, I know, Jane, we were going to talk about this on our show before COVID happened, about, like, you know, primary care overall and how that could be enhanced. But, oh man, that would be devastating, because that's like the cornerstone of our healthcare system, you know.
Well, it's certainly been, this has been really tough on primary care providers, and particularly those who have are funded by fee-for-service models. This has not been a good time for them, and many of them aren't feeling well supported. I think Brian's raised a very legitimate concern.
I hear you. I hear you. So, unless there's any pressing issues, we do have a boatload of questions from the all the people streaming, and so I think we'll just address these if it's okay with you guys. Do you think changing the directives on the topic of face masks impacts public's trust of public health experts? What are your thoughts on the use of face masks currently for the general public? You guys have a sentiment on or thoughts on face masks overall?
They seem to reduce
I'll address the part about, you know, I think people changing their minds, scientists changing with the science. I think that should happen. I don't know why that would upset people or discourage them. It should do quite the opposite. It's like, hey, we learned stuff, we're going to change our recommendations. That's how science should work. That's how healthcare should work. I just don't understand this notion that, oh my God, they've changed their mind, they're horrible. Quite the opposite. I'm not a great enthusiast about masks. I think masks are useful, but I worry that the way they're used, people think they're a substitute for everything else. So I think masks have a place in public places, etc. But we have to make sure that they're not used as an excuse to not social distance, to visit, you know, to have a party. Let's have a party and we'll all wear masks, you know. So I think we have to recognize the unintended consequences as well as the benefits and some of the possible risks.
I agree with André. You know, and you know, I will note that organizations like the Centers for Disease Control, the World Health Organization, the Public Health Agency of Canada have gone from being very tepid on masks to being much more positive about them. But André is absolutely right. They are not an excuse to abandon hand washing and physical distancing and all the other measures.
All right, I take it, Jane, you don't want to. I can read your body language. We can leave
These guys have said it all.
Okay, perfect.
She's waiting for a better question.
Yeah, there you go. I want to say one thing though. And take this with a grain of salt. I feel like traditionally in medicine things move slow, and one thing another positive I would take from this is the willingness to be nimble and to adjust with what we see in front of us, I think is something to be commended, because I personally at the bedside have seen our willingness to change affect lives and potentially save lives. And so I do want to say, echo what André is saying. The fact that there was some changes of opinion, to me, is actually a good thing.
I think Canadians should get some of that credit too. I mean, I think healthcare providers have been pretty nimble, but Canadians have been incredibly nimble when you consider nobody knew the term physical distancing at their New Year's Eve party, and now it's part of our everyday language. And Canadians have adapted extraordinarily well. I mean, people around the world have had to, and it's amazing when your life is at risk, the changes that you'll make. But when I get teary-eyed when I go to the grocery store with my mask on and watch other people, and people are sad, and there's sort of this sense of, is our life really going to always be like this? And it just doesn't feel the way it used to feel. And people are afraid to look at each other because somehow they think that, looking at someone will potentially transmit virus. But at the same time, I look around at people and I say, I think I'm really proud of you. I'm proud of the way that people have done what it takes, and nobody's loving this, but we're looking out for each other, and that's pretty special.
Wow.
Yeah, the pandemic's a good reminder of how resilient people are, how adaptable we are, because we've changed incredibly in a very short time, and most people are doing okay with it.
100%. Okay, next question. Do you think there'll be another full lockdown based on, if there's a second wave, do you think we'll be proceeding with another full lockdown? That's a tough one.
Depends if we can get our act together on testing and contact tracing.
I meant to ask, sorry, Jane.
No, if people don't want another lockdown, then we're going to have to figure out how very quickly to make sure that as André alluded to earlier, then when there's an outbreak, boom, we're on it. We've got all the appropriate people tested, rapid turnaround on contact tracing. I think the workplace issue is a big thing. There should be ways to be able to do surveillance in workplaces that would prevent us from having to lock down.
Mm-hmm.
So it's going to be up to us. Well, us.
I think locking down gets more and more difficult as we go along. We did the one biggie. People made a lot of sacrifices, but it gets harder each time. I think we have to figure out ways to control this. I always say we need to learn to live with the virus instead of in fear of the virus. So I hopefully gone through the fear period, and now we're going to get to the adaptation. How are we going to do this? Live with it. When we do have surges, how are we going to deal with them? And I don't think it's going to be by shutting down the economy. It might be by shutting down parts of it. Maybe our meat plants are going to close for a few months until we figure that out. Things like that. I think that's what the future holds, rather than these big lockdowns, because they're very, this was not a very subtle gesture as we closed out everything. And in retrospect, we probably didn't need to, but we can learn from that going forward. I'm not big on trying to rewrite the past, but I think in the future, we can learn from the past a lot.
Mm-hmm. Yeah. Thank you for that. One of the questions here, we did touch on virtual care. What changes will be permanent? So, Dr. Jane Philpott, can you speak about the governmental response and how the division of powers between federal and provincial impact our abilities to respond to the pandemic? Is that fair? Or you?
Oh, sure, it's fair. I mean, I'd like to hear what the other guys have to say on this too, because they've thought a lot about it. As I said earlier, I mean, Canada's a big country geographically, and even within, province, we talked about the fact that there's regional variation, and so you have to enjoy the benefits of regional variation. But I do think that where we have really done well in Canada is when we have decided that there are certain things that we're going to agree on as some basic principles. You know, the best pieces of legislation around healthcare have happened at the federal level. You know, you look at the Medicare Act of '66, the Canada Health Act of 1984, where we decided that we were going to make sure that Canadians had at least hospital care and doctor's care on the basis of need and not on the basis of ability to pay. That was probably the most important single piece of legislation from a healthcare perspective that the country has ever had, although there were pieces of legislation that led up to that, but we've enjoyed the benefits of that. While not perfect, it has kept a heck of a lot of people alive. I think it's time to look at other areas in which we need to have national standards, and there needs to be strong federal leadership. And I personally think that long-term care is one of them that we talked about earlier. Sure, it could be fixed from province to province, but provinces do have standards, and then of course they have their own ranges as to how well they actually follow up on the standards, whether or not they have proper processes for accrediting and checking on facilities. I think this is an area where if we're going to study anything, I think we need to look at what it would look like to set national standards, to have federal funding for not just long-term residential care, but the whole spectrum of care of the elderly, from home care to long-term care, so that people will know that when I grow older, I will have access to the care I need, and it will be of a standard that we all believe is fair and dignified.
Yeah, I think Jane said it well. I don't think there's any. Unfortunately, we can't have a Canadian discussion about healthcare without talking about the Constitution, so that's frustrating. But I think there's no legal impediment to doing the right thing. So I think we have to sort of drop a lot of this posturing and say, listen, we're going to have standards. They don't have to be federal. They can be national. Means they're agreed upon. And there's no reason we can't do that in all kinds of areas. There's no reason that the way Ottawa's spending money, they can't spend some of it smartly on helping encourage provinces to fix long-term care. So we have to respect the jurisdictions, but we also have to, I think, respect the population. And they don't give a crap about, these divisions of power. They care about the care being delivered to their granny. And that's what we have to focus on. So it really bothers me when this becomes an excuse for not doing things. There's no reason that we can't fix this stuff nationally, federally, provincially, by sitting down in a room and agreeing on stuff that we know we should agree on.
In addition to long-term care, I wonder whether emerging infections, global health threats, couldn't be rationalized as being in the federal file. That should be federal jurisdiction, if you think about it. In an age when we have international travel, people traveling all over the world, landing potentially in any province, why is it a provincial responsibility? Why not make that file belong to the federal government, along with the resources that are necessary to go with it? And to Jane's point, I think money talks, and I think a federal government that wants to be more involved in healthcare and guarding the health of Canadians needs to put more money into it. And we know that federal funding for healthcare dropped fairly substantially over the last 20 years, 25 years, and I think it's time to take another look at that.
Good points. Thank you for that, guys.
Can I just put in a plug for national data too?
Do it.
Yeah.
I'm embarrassed as a Canadian that, God bless the folks who work in the Public Health Agency of Canada. They are good people. They're working really hard. They're a very small department in the big picture of things. But they have their hands tied behind their backs trying to get data on anything. And this was an issue, when I had the portfolio and I was trying to get information on how many people were dying of overdoses. And we could not, as a federal government, oblige the provinces to provide that data to us. You almost have to go begging to say, here's how we'd like it delivered. This is the kind of information, and would you all agree nicely to send us that data in a similar manner so that we can get a picture of what the heck's happening across the country, and is there any chance that we could do it not 18 months after it happened, but when it happens. We're same thing again. We do not have the federal government and the Public Health Agency of Canada do not have the legal authority to ask provinces to hand over their information. And, you know, they do put out data, but it's pretty patchy. It lags tremendously, and it's reported differently from every part of the country.
That to me is like no excuses. Like that to me is crazy. Like this stuff should be standardized. The amount of like how important it is to have reliable data. Like we look at we just did a webinar on the prognosis of ventilated patients. So there's a paper comes out of JAMA saying that over 80% of patients on ventilators don't survive. And this was not what we were seeing locally. We were not seeing anywhere near those numbers. And this is going out, and it was affecting people's judgment. We're talking about stories where 50-some-year-old people that needed to be put on a ventilator were like saying, "Oh, maybe actually I don't." I read the news and saying how I'm not gonna get better because I'm on a vent. Like, this is insane. And for us to not have standardized throughout the provinces, here's the data we need to make our decisions, and to produce good science too, and good papers. I don't know. It's one of the things that to me has always baffled me. It comes down to like even the fact that we have in Ontario, even in this city, how many EMRs are there?
Don't get us started.
I'm sorry, I didn't want to open that box, but the point is, it doesn't seem like something that would be that much to ask, but is super important. How about that?
Yeah, let's stop faxing data to each other, maybe to start with.
We need really fax machines, Andre.
Yes.
Oh man, this is what I'm saying about slow to adapt. Fax machines, pagers. I got a pager in 2020. Like, I'm playing hockey and people will see the pager on the bench and be like, "What is that device?" I didn't know that these still existed. Okay, this question actually is one of my favorites actually. How are we going to deal with wait times as a result of what the lockdown?
You mean the backlog in cases that have been postponed? Oh boy, that's a huge challenge. And now there are opportunities here. When I spoke to the vice president of clinical care of surgery at University Health Network, he was talking about for the very first time arranging a triage list of patients who would be called back in for their semi-urgent and elective procedures, and there for the first time there would be communication between different surgeons over the merits of who's at the top of the list and who's second and third. I think we need to do that. I think that certainly we need a group of wise people. So not just one surgeon, for instance, saying advocating for their patient, which is important, but they should be advocating to a committee of wise people that's using data and metrics to decide who is closer to the life and limb criteria and requires treatment more urgently. And I would hope that in addition to life or limb, they'd be looking at quality of life as well as an indicator of whether somebody should be moved up the list or down the list.
Any takers? The actual original question was whether we think privatization has a role here, considering some of these wait times and the backlog of cases. Any thoughts on that?
I don't think that's really a factor. I think we only have so many surgeons. We only have so many operating rooms. We have to figure out how to use them more efficiently to alleviate some of the backlog. So the good news, if you could put it that way, is I think we use our operating rooms really inefficiently now. So there's a lot of opportunity there to clear up some backlog pretty quickly. You know, nobody ever operates after 3 p.m. We can fix that. There's lots of things that can be fixed immediately. My other part of the wait puzzle is I hope we never see people in hallways again, right? There's been no hallway medicine for 2 months. That's magic. Let's make sure that we don't start having people on stretchers for 48 hours again. I don't know how realistic that is, but I think we've demonstrated it's doable.
I would just echo what the others have said in terms of this is an opportunity for creativity. We've always known there are weird things about how operating time gets dispersed, and you know why we have operating rooms sitting empty for 2/3 of the time. Now's the chance where we've got backlogs, where we've had money that would have been spent. Not that there's a lot of money to go around these days publicly, but there are a lot of procedures that would have been done over the last 3-4 months that haven't been done. Some of them can be done after hours, and this will force some of the change in hospital care that's been a long time coming as well.
You know, there's an interesting point, and I don't know, Claude, if I misinterpreted your question to mean dealing with the backlog of cases, because you know, I've heard some estimates that it could take 18 months to 2 years to clear a backlog that took just 2 to 3 months to develop. It would be very easy for us to say, as a panel, to say that operating rooms should be running 24/7 to get through the backlog of cases, but there are union wages to pay, there's overtime to pay, and it would be so tempting for provincial governments to say, look, we can't afford that. We're just, people who waited, if they have to wait longer, they're going to have to wait longer. I hope that doesn't happen. I hope we get creative with solutions, but it's easy for us to say, let's just clear the backlog, but I think God's in the details, and how that happens, I think is going to be interesting.
Yeah, I mean, certainly I could speak for a lot of my colleagues. I know we were saying there's a limited amount of docs that are available. There's a lot of unemployed surgeons, and there's a lot of I think of my orthopedic colleagues that are on their, I don't know, 3rd fellowship, maybe getting a PhD in the right toe. The demand is high. So I think that's why I thought this was a fair question. But I mean, I do also think there is tons of room for efficiency. But as you mentioned, the devil is in the details. There's going to just maybe 2 more questions. Considering that one of the leading causes of death in Canada is due to chronic disease, obesity, diabetes, hypertension have negatively influenced patient outcomes during COVID, what are the areas that can be improved in our education and healthcare system to promote preventative approaches and improve health? Maybe we touched on this a bit, was a bit on the behavioral science but it's true. I must say, in medical school, the preventative element of health, I wouldn't say it was ultra emphasized. I know, Andre, I feel like this is up your alley. Do you have any thoughts towards that?
Yeah, I think prevention's important, but I think even more important, a lot of these illnesses like diabetes are linked to socioeconomic circumstances. So I think we haven't talked about this, but I think one of the single most important health initiative that's happened during this pandemic is income support. I think the federal government deserves a lot of credit for what it's done to bolster people's income, to prevent people from starving, which was really a possibility, which is happening in other countries. I think they've done a tremendous job, and it's reminded us that that's the single most important thing for our health, is having money to buy food and to put a roof over your head. And I think it's also brought us a lot closer to a discussion of basic income. So I think some really good, and that's would be really good for the health of our country and for Canadians. So I think there's really, you know, we can talk about prevention and get people to exercise and stuff, but they have to have the ability to do it. And the way to have the ability to do it is to have security, income security, housing security, food security. This is all the stuff that makes us sick, not the fact that we don't exercise. People, those of us who exercise have the luxury of doing it, just like we have the luxury of distancing and isolating, that other people who are at far more risk didn't have that luxury.
This would be a good time to put in another plug for family medicine and primary care too, which you referred to a little bit earlier. And I do worry about the long, you know, people talk about excess mortality and collateral damage related to the pandemic. And there's certainly been lots of that in the short run from people who have avoided coming to the emergency department, and especially in the early days. But there will be long-term collateral damage just from a whole slew of deferred, delayed, absent preventive care, chronic disease management. People have not been seeing their family doctors or their family health team, their primary care provider in the way that they normally have, and that will have long-term consequences. So, you know, this is the bread and butter stuff that people don't see that happens behind the scenes. Those regular visits to make sure that people are actually having their chronic diseases managed properly. You know, you don't want to go many more months without people getting that kind of preventive care. Pap tests,
I think that's an important
mammograms.
point. That, we've talked about all these folks in long-term care and how they've suffered, but most seniors live in the community, and many of them live with these chronic illnesses. They've been deathly scared to get medical help. And I think you're right. We're going to see the consequence of this. You're going to see it in ER for months and years to come.
Well, guys, I wanted to try and end on a more positive tip, and I'm just trying to think of how to leave Let's Start. I mean, one of the things that we've been preaching, like on the show, and I got a couple articles on CBC, is really, you know, it's not all doom and gloom. We've done a lot to prepare. If we look at how we've done compared to other regions of the world, I think there's a lot to be commended. But, you know, I think ultimately, though, we have like all considering some pretty good public health, and I think that at the end of all of this, we're going to overcome and be okay. And I think we've shown a lot of grit and a lot of determination, and I think all these efforts that Canadians have been making and has been like clearly beneficial to our people. So I think despite of a little bit of doom and gloom, I think we will still overcome. I just wanted to, any parting words actually, guys, before we say goodbye?
Yeah, I'd like to shout out people like Andre and Carly Weeks and Kelly Grant and you know, Teresa Boyle and Jennifer Yang and all the other reporters who've been working in this very precarious journalistic environment, bringing us story after story. You know, Mike Crawley, my colleague at CBC, and all the people, all the public health specialists, the epidemiologists like, you know, David Fissman and Isaac and infectious disease consultants like Isaac Bogosh, who donated their time on social media, who have kept us all up to speed on what's going on. Without them, we would not be able to ask some of the questions that we've been able to ask, let alone try to answer them. So that certainly has been an incredibly positive development. And, you know, it's a reminder to me just how important journalism is to buttress our democracy, but, you know, especially at a time of crisis like a pandemic.
I'll echo that. Any parting words, Andre or Jay?
Well, I'll just say this may be unusual for a journalist, but I think we have to give a shout out to our politicians. I think they have a thankless task. They've risen to the challenge in virtually every jurisdiction. We're hard on them, but we've had a tremendous response politically, great solidarity, a word we love in Quebec. Canadians have really rallied. You know, we haven't been near as partisan as other countries, especially the US. People have really come together and said, listen, let's do what's for the common good. Doesn't matter if we're liberals or conservatives or NDP. Let's, you know, agree on this and bring in programs that help people. And I don't think they get enough credit for that. And Jane knows this all too well. They get a lot of crap and they don't always get credit where it's due.
And I'll jump in with one other positive thing to say. I think this last few months has shown us how much we care about each other, and has helped us to really focus on what we miss most, the people we miss, the opportunities to be able to hug one another, reach out and shake hands, touch one another. This has really forced us to look at what means the most to us, gathering together with friends and family and coworkers. We miss a lot of that stuff, but there's going to be a day where we're going to be able to hug each other again. And I hope that we never forget what it was like when we couldn't do that. So here's to the day that we can give you a high five and actually touch one another.
A high five, absolutely. I'll be bear hugging you, André and Brian, for sure. Listen, guys, this has been amazing, like truly amazing. And I really want to thank you for being able to take the time and be able to discuss these issues. And I really think we're better for it. Like I feel more informed. I feel more, more hope. And I think it's amazing that you guys were able to do this, and I hope to do it again, actually. So thank you so much for doing this.
Thanks so much for having us.
Thank you. Thanks for having us.
Take care, everybody. Stay safe. Thanks for tuning in, and we'll have the video version on YouTube and the podcast released tomorrow. Thanks for listening in, and take care, everybody. Yay.